Hello, everyone. My name is Patrick O'Malley. I'm a board-certified emergency physician with 15 years' experience in managing lacerations from residency to community emergency medicine and urgent care practice. We're going to talk about how you, as a primary care physician, can come up with an effective approach to managing lacerations in your clinic setting. Let's get started. It really is a conundrum. You're in a busy practice, overbooked appointments, 15-minute time slots to manage complex medical issues. One of your patients calls your office stating that they cut their finger on a knife while making breakfast and wants to come to you for repair. They call the office and are told that you do not do that at your place and recommend that you go to the emergency department. You never hear of the call and go about your day. The patient comes back a few weeks later for a routine office visit and tells you about the laceration and their horrible experience in the emergency department. You tell your patient that you would have been happy to have done this for her and wonder what happened. From my experience in the emergency department and urgent care, I will oftentimes call and speak to the physician about a particular issue, and what I've found is that many patients get referred away from the primary care office by the person answering the phone. They are making decisions that affect you, your patient, and your bottom line. Plain and simple, you want to be able to care for your patients. Sending them to the emergency department or urgent care for simple issues like this erodes trust and is lost revenue. In all fairness, it does take some time and resources to manage lacerations. What do you do? It's important to sit back and ask yourself, how do you change this? We're going to go through all of these points in more detail. Briefly, you have to address staffing issues. Consider having a set period of time for walk-ins and procedures. You also have to have basic suturing and wound management equipment available. It may have been a while since your emergency department rotation and residency, but you may need to brush up on your suturing skills. The billing and coding aspects of laceration management may be foreign or intimidating. We'll discuss these. Lastly, we'll talk about relationship building with local physicians when they are needed. Staff. Find out who is taking phone calls from patients. Is it the front office staff who just started working last week, or is it a seasoned nurse who you trust? If you run a private practice, it may be easier to have a direct line of communication with these team members. Let them know that you are in fact able to manage simple lacerations. Tell them what you are and are not comfortable with taking care of. If you're an employed physician in a large hospital system, you may have to go through 15 layers of management in order to be able to properly address the situation. Tread lightly, as some office managers may be taking orders from someone above them. I would recommend for this particular situation, and possibly others, have them talk directly to you before referring the patient to urgent care or the emergency department. Train your staff. Have a dedicated team member who may express interest in this and give them the responsibility of setting things up for you, anticipating what you'll need. It's a good idea to have everything you need for acute wound management in one specific location. I recommend a rolling cart that has everything you need and it can be rolled into each individual examination room when needed. You may have a dedicated procedure room. This would be a great place to store everything. There are several aspects to timing. You do need to be familiar with recommendations for timeframes in which it is safe to repair lacerations. In general, most lacerations should be closed within 8 to 10 hours of injury. There are some caveats here. Face and scalp wounds can go a little bit longer, leg and foot wounds a little bit less. If diabetic, the time frame is less due to peripheral vascular disease and increased risk of infection. That's a full lecture unto itself. From office timing standpoint, consider having a time slot at the end of your morning block or at the very beginning or end of the afternoon block. With proper training of staff, they can anticipate everything that you will need and have everything laid out for you. You can anesthetize the wound, have them rinse the wound out at the sink. You can go and see another patient, come back, repair the laceration, and discharge them quickly. If your office utilizes physician assistant or nurse practitioners, this may be something for them to take on. The equipment that you will need for laceration repair in the office setting is really not that much. The old days of having an autoclave and all the hassles associated with them are long gone. Don't even consider using an autoclave for this. Multiple manufacturers make single-use laceration kits for this purpose, and I would highly recommend that you talk to your equipment supplier. I take this topic very seriously and want you to understand that not all single-use laceration kits are made equal. Full disclosure, I do some consulting work for Centurion Medical Products and Medline Industries, but I do firmly believe that they make the absolute highest quality single-use kits available and would encourage you to look at their products. You'll need some larger syringes such as a 30 or 60 cc syringe for irrigation, a splash guard, and some bottles of saline, although tap water is completely safe and effective. For anesthesia, have a few bottles of lidocaine with and without epinephrine. If you will be managing lacerations in children, topical lidocaine, epinephrine, and tetracaine, known as LET, will be very helpful. Use high-quality surgical stapler. These are usually around $6. It's fast and an effective way to close a significant number of wounds. These are much better than the 5-shot cheap staplers that you may have used in the past. Do not use them. Spend the extra few dollars and get a good stapler. Dermabond and Steri-strips can also be used to close many wounds that you may encounter. They're easy to apply, they're painless, and do not require a repeat visit. I would recommend having several sizes of non-absorbable suture, such as Prolene or Ethelon, with 6.0, 4.0, and 3.0 sizes. This should be all that you truly need. I'm not an expert in the pricing of all these, but I imagine for less than $100, you should be able to have a decent supply of suturing materials which would allow you to handle most anything that presents to your office. The actual act of repairing wounds. This may provoke some anxiety for you, and I completely understand. Maybe you have some PTSD from your residency days repairing that ghastly scalp laceration on the drunk guy at 2 in the morning in the emergency department. It may have been a few years since you've touched a needle driver, and the thought of repairing lacerations is somewhat intimidating. I can reassure you that you've got this. Many options are available if you want to seek more information. There is an overabundance of suturing videos available online. You may want to take a comprehensive course, such as the laceration course that I've put together. You may want to go and do an in-person skills workshop. The videos I used in my course can be found at the link listed here. These were done by a plastic surgeon in North Carolina, and I have found them to be incredibly effective and helpful. Lastly, you may want to consider getting a practice suture kit and pads so that you can practice and brush up on your skills at home. Follow the link listed here. Regardless of how you do it, suturing does take practice, and I would encourage you to take some time and learn the basic aspects of interrupted sutures, mattress sutures, stapling, dermabond, and Steri-strip placement. The billing and coding aspects of laceration management are not overly complex. See these links here, which should be able to give you most everything that you need. If you really want to learn more, you can take a CME class or talk to your office coder, and they may be able to sit down with you or talk to you on the phone for a brief primer on this process. The most important part of coding is looking at the length, depth, and complexity of the wound and the anatomic location. You'll need to document if it was external sutures only, if deep sutures were used, and if there was any debridement. All of these contribute to the complexity of the wound and will dictate how much you are reimbursed. My comprehensive course has an entire lecture on this if you would like to learn more that way. It goes without saying that your patients want to avoid the emergency department and urgent care if at all possible. Sometimes it's just unavoidable due to the complexity of the wound, your schedule, clinic hours, etc. I do believe it's important for you, as the primary care physician, to develop relationships with a local emergency department or urgent care that you trust. If you see a patient that has a laceration that's beyond your capability, it's a good idea to either call the urgent care or the emergency department and give them a heads up that the patient's coming. It may also be helpful, depending on where you are and the resources available, to develop a relationship with a general or plastic surgeon that you can refer these patients to. Depending on their schedule and availability, they may be able to work the patient in and repair the laceration in their office. Your patient will appreciate your effort and would be much happier going there instead. Don't get me wrong, we love repairing lacerations in the emergency department, and this is our bread and butter. But that extra personal touch that your patient appreciates will be made even better by this relationship building on your part. I hope that you were able to get some useful tidbits of information, and I encourage you to consider taking care of these patients in your office if at all possible. I am passionate about this topic and would be more than happy to answer any questions or do anything that I can to be of assistance to you. If you're interested in learning more, please take a look at my course, found at www.thelacerationcourse.com. My email and phone number are listed here. Don't hesitate to reach out. If you're on LinkedIn, send me an invitation. I would love to connect with you. I'm very much interested in working with primary care residency programs. Please let me know if you're affiliated with such a program. I would love to help out in any way I can. Thank you for your time. Now get out there and start suturing.